right, Dr. Serafini, you are welcome to start whenever you would like to.
Okay. Do you think, I guess, I can see, I'm not sure if I can see many people's, I guess I can start. Some of you guys already joined. Okay. So, hi everyone. My name is Federica Serafini. I'm a first year ACVNU resident. I'm currently working at Purdue University as for internal medicine and nephrology urology service. So today I pick a paper just published on Journal of Veterinary Internal Medicine from a group from Ghent University focused on alteration in gut-derived uremic toxins before the onset of azotemic chronic kidney disease. Okay, so before proceeding with the paper, let's jump into some background, starting from human medicine. In human medicine, there is a growing body of evidence that highlight the connection between the gastrointestinal tract and the renal function, named the gut-kidney axis, that is very important during chronic kidney disease, has a critical role in the morbidity and progression of the disease. A well-balanced gut microbiome is essential for an immune system, nutrient absorption, preservation of intestinal barrier, the synthesis of short-chain fatty acids, and also the defense mechanism against invading bacteria. The uremia associated with chronic kidney disease has been proved to cause dysbiosis that is evident with the reduced number of microbial richness, and also with a decreasing microbial diversity characterized with the domination of certain bacterial families. During chronic kidney disease, urea concentration increases in the bloodstream and subsequently diffuse into the intestine, and certain bacteria will hydrolyze the urea into the ammonia, and this leads to increased luminal pH. That is one of the main causes that is associated with dysbiosis during chronic kidney disease. Some additional factors contributing to dysbiosis include the regular usage of antibiotics, phosphate binder, and the reduced fiber consumption. Interestingly to me, there are over 100 uremic toxins that are generated by gut microbes, and those toxins will differ based on the size, the protein bind affinity, the level of toxicity, and obviously what tend to accumulate as the glomerular filtration rate decrease. In human medicine, there are different ways to classify these uremic toxins. The one that I picked and I like the most is dividing the gut-derived uremic toxins in 4 categories, non-overlapping categories. So water-soluble, low molecular weight, divided in non-protein bound and protein bound, middle molecular weight, and high molecular weight. The most common uremic toxins that we all know, creatinine, BUN, and SDMA, are water-soluble, low molecular weight, non-protein bound. But the major gut-derived uremic toxin in patients with chronic kidney disease, such as, I apologize for the pronunciation, trimethylamine N oxide, TMAO, is a water-soluble low molecular weight non-protein bound, and then the other toxins such as indoxyl sulfate and picrisyl sulfate are instead low molecular weight protein bound toxins. And this is important in human medicine because the accumulation of these toxins is definitely problematic for people with end-stage chronic kidney disease and patients that are undergoing chronic hemodialysis. There are several studies on finding the best hemodialysis technique because a routine one is not able to remove these toxins efficiently. And so some hemodiafiltration or specific cartridges are needed or adjust the duration of the sessions. And so, as I mentioned, the one that I focus today that are mentioned in our paper, the gut-derived uremic toxin, indoxyl sulfate, picrisyl sulfate, and trimethylamine N oxide, TMAO, that are generated from dietary amino acids and then protein catabolism from the bacteria. And so in particular, we have on the left of the screen the dietary amino acids, such as tryptophan, tyrosine, choline, carnitine, and for example, betaine. Those are starting from the tryptophan, undergoing, I'm so sorry, undergoing bacterial metabolism, in particular E. coli, Proteus, and Bacteroides. We have the formation of indole. The picresol is generated by partial breakdown of tyrosine and phenylalanine by intestinal obligate or facultative anaerobes, such as Bacteroides or Clostridium, for example. And then lastly, the TMAO, actually TMA will be secondary to bacterial metabolism, in particular from firmicutes, like Clostridium or Proteobacteria, starting from choline, carnitine, and betaine. All of these intermediates are undergoing, passing the tight junction in the intestine, enter the circulation, and undergoing liver metabolism. Most importantly, conjugation and oxidation, and there is the formation of the protein-bound uremic toxin. The toxin then are mostly excreted by the kidneys, involving tubular transporters, and in some small portion also eliminated by glomerular filtration. And so in human, again, there are several studies published on the topic and understanding if the gut-derived uremic toxin can be a component on the development, so the initial damage and then the development of the chronic kidney disease, or are more factors for the progression. And so more recently, the more recent studies are associating with this, this toxin with more progression and continuous damage of the kidney, in particular, exacerbating intrarenal inflammation, tubular interstitial fibrosis, activating the RAS system, and also cellular apoptosis. But there also are causing CKD-associated complication. So this toxin can decrease the APO production, causing endothelial damage and cardiovascular complication, atherosclerosis, thrombosis, have an impact on the metabolic dysfunction, for example, insulin resistance, sarcopenia. They will directly disrupt neurotransmitter balance and causing neuronal decreased neuronal function, and so cognitive decline in human, and lastly, contributing to osteoblast and osteoclast decreased function or impairing the function of the cells. So now going back to what the information that we have in veterinary medicine, in particular with cats with chronic kidney disease, and I choose to present a couple of papers. The first one, this is a study, multicentric, like from Colorado, Ohio, and Texas University, published from 2019 on Journal of Veterinary Internal Medicine. This paper included 30 cats with chronic kidney disease, 11 healthy cats, older cats. So what they show is that cats with chronic kidney disease have decreased fecal microbiome diversity and richness compared to healthy cats, and as shown here on the graph on the right, cats with chronic kidney disease stage 2 and cats with chronic kidney disease stage 3 and 4 have elevated indoxasulfide levels compared to the normal population. In this study, precresol sulfate did not significantly differ between the two populations, but the highest concentration were detected in cats with chronic kidney disease. This one is another study on the evaluation of renal transporter gene expression and uremic toxin in cats with chronic kidney disease. This was recently published in 2024 on Aging Journal, and was done by a group of researchers from Purina in the United States and in Switzerland. This paper included different groups. The first cohort included 28 cats as a control and 13 cats with chronic kidney disease stage 2. These cats were from a colony in North America, and they analyzed the gut uremic toxin and showed that TMAO, indoxyl sulfate, and picrosyl sulfate were 3 times higher in cats with chronic kidney disease stage 2 compared to healthy. And also, these toxins were increased in more older cats, so cats greater than 12 years old compared to younger healthy cats. For the second cohort, this one included client-owned cats from Europe, and they included 10 cats for each group. So 10 cats as a control, 10 as a CKD stage 2, and 10 as a CKD stage 3. They showed that TMAO indoxyl sulfate were 1.6 times higher in cats with chronic kidney disease stage 2 and 3 compared to control. And also, picrosyl sulfate was increased in cats with chronic kidney disease stage 3 compared to control, but they didn't see or show any difference in uremic toxins level in healthy cats based on age. And then same study, they had a third cohort, included 24 cats that were euthanized for other reasons unrelated to the study, and they were able to collect renal tissue, in particular from 6 healthy cats, 8 cats with chronic kidney disease stage 1 to 2, 7 cats with chronic kidney disease stage 3 to 4, and 3 cats with amyloidosis. They showed the evidence of the expression of renal tubular transporter genes, O81, O84, O80P4C1, and ABCC2 in cats. They did not reveal the expression of O83, that instead is an important transporter in humans. The transporter, the expression of the genes, in particular O81 and O80P4C1, is downregulated in cats with chronic kidney disease. So now going back to the study, the paper that I'm going to talk about, the major goal of the paper was to investigate the relationship between gut-derived uremic toxins and development of azotemia. And then they have also a few more goals. They identify differences in gut-derived uremic toxins pathway between healthy and cats that develop chronic kidney disease using a follow-up on healthy senior cats. They want to determine if increased amount of toxins could predict the onset of azotemic chronic kidney disease. And lastly, establish whether impaired handling of gut-derived uremic toxins is evident before the onset of CKD. The study design, they use a nested case control study, including a prospective follow-up on healthy senior cats older than 10 years old. The outcome was the development of azotemic chronic kidney disease diagnosed as creatinine above 1.83 milligram deciliter and with a USG below 1035. Cats were screened and re-evaluated every 6 months for 2-year period. And every time there was another clinical relevant morbidities, the cats were excluded. And so, again, as I mentioned, urine and blood samples were collected every 6 months. Metabolomics analysis were performed for specific gut-derived uremic toxin, induxial sulfate, TMAO, and picresol sulfate, their intermediate, and then also the dietary precursor and amino acids. The same group of authors published the design, optimized, and validated the protocol used for the metabolomic studies analysis using ultra-high performance liquid chromatography and high-resolution mass spectrometry. The statistics, normality was assessed using Shapiro-Wilk and visualized as histogram and Q2 plots. Serum and urine uremic toxins and precursor were compared at all the time point using Mann-Whitney or student test based on the distribution of the data. The progression of specific metabolites over time was evaluated using Friedman test. Multiple comparisons were performed and corrected using Benjamini-Hochberg method. Assessment of predictability and association between uremic toxins with the development of CKD was done using univariate binary logistic regression analysis and corrected or adjust for possible confound factors such as age, creatinine, STMA, USG, and UPC. And lastly, correlation between uremic toxin and variable used to predict the development of CKD were performed using Spearman analysis. So for results, they initially included 171 cats, but only 127 were actually used, included in the healthy study population and used for the longitudinal follow-up. The main reason for the exclusion was hyperthyroidism, FIV, pre-existing CKD, and few more other morbidities. So the 127 cats were followed, and then urine and serum were collected every 6 months. And every time a cat was diagnosed with CKD, the cat was moved to the CKD development cohort. And so by the end of the study, there were 22 cats in the CKD development cohort, and those cats were backtracked at time of diagnosis, 6 months prior to the onset, and then 12 months prior to the onset of chronic kidney disease, where we can see here there were only 15 cats on that period of time. And then there were 72 healthy cats that at the end of the study period remained healthy. And those were randomly sampled 26 and then backtracked at the same way at the time of diagnosis, 6 months diagnosis in terms of compared to the CKD group, 6 months prior and 12 months prior to the development of the CKD in the other group. Again, for results, the cats in the CKD cohort were 2 years older than the case control. Systemic blood pressure and body weight did not differ between CKD and healthy, and there was no clear trend of weight loss. For blood work, SDMA, but not the creatinine, was higher at baseline in cats that then developed CKD. At 6 months before the onset of CKD, SDMA and creatinine were higher in the CKD group. And as mentioned here, the 18% of the cats was actually above the reference range for SDMA value. And instead, creatinine showed a continuous progressive increase up to the onset of CKD. Urine analysis, the USG was decreased at baseline in cats with chronic kidney disease, with showing a downward trend, and there was no difference in UPC, and also was the values were stable over time. So here, this is on the left is a picture from the paper that I adjusted for the presentation. Is showing the uremic toxin pathway. So starting from the left, hopefully you can see my pointer. We have dietary amino acids, and then in this case, tryptophan, the gut-derived bioproduct, indole, and then after liver metabolism, our gut-derived uremic toxin, indoxyl sulfate, and finally, the last step, the urinary excretion. And so here in the mid portion of the picture, we have box and whiskers with the green one are showing the healthy cats, and then the colored one, so the yellow, it's the cats 12 months prior of the diagnosis of CKD, orange 6 months prior, and then the red at the time of diagnosis. So what we can see with the stars is that indole and indoxyl sulfate showed a significant increase in serum, but not urinary excretion 6 months before the onset of CKD and at the time of the diagnosis. The indole and indoxyl sulfate level were not significantly different between cats that will go and develop CKD at 12 months prior to diagnosis compared to the healthy. Same for the other toxins. So the uremic toxin pathway starting from amino acids, betaine, byproduct, gut byproduct, trimethylamine, and then the after liver metabolization, TMAO, and then the urinary excretion. Here we can see that there is no significant changes over time and between CKD and healthy for the amino acids at any time point. The serum and urinary TMAO showed significant upward trend during azotemic CKD development over time. And also there was a significant increase in serum and urinary excretion of TMAO observed 6 months before the onset of azotemia between CKD and healthy, and at the time of diagnosis as well. Lastly, again, uremic toxin pathway from tyrosine, picrazole after gut microbial byproduct or metabolism, and then after liver metabolism, picrazole sulfate, and the urinary excretion. The picrazole and picrazole sulfate only increased at the time of diagnosis compared between CKD and healthy. without showing a significant upward trend over time. And I'm sorry. And also, there was no changes in the amino acid precursor, and also the urinary excretion of peak creosote sulfate between the two groups and over time. Based on univariate binary logistic regression, showed that for each increase of toxin, indexyl sulfate, TMAO, and peak creosote sulfate, it was associated with increased risk of development CKD 6 months before the diagnosis. However, the peak creosote sulfate association was weaker and was the weakest, and also lost completely significance after correction for adjustment for the possible confounder, again, creatinine, SDMA, USG, age, and UPC. And the predictive value of indexyl sulfate and TMAO also diminished after adjustment for this variable. Lastly, TMAO has the highest odd ratio of 3.9 for progression to CKD, while the indexyl sulfate for each unit of increase, there was a 3.2 high, like more likely to develop CKD. As a discussion, so the study showed alteration of gut-derived toxins and related pathways in older healthy cats associated with the development of azotemic CKD. They showed that gut-derived uremic toxin indexyl sulfate, TMAO, increased at least 6 months before diagnosis of azotemic chronic kidney disease, and no changes over time for peak creosote sulfate. Based on the statistic and the results, the increase in circulating indexyl sulfate and TMAO likely to reflect an already decreasing glomerular filtration function, rather be the cause of the initiation of renal function decline. And so the author hypothesis was decreasing GFR causes initial retention of indexyl sulfate, that it will be counterinteracted at the beginning by increased tubular secretion, but as CKD progresses, there is a saturation of tubular secretion and worsening retention of toxin in circulation, causing a vicious cycle. Discussion, the authors also mention different approaches for decreasing uremic toxin, including decreasing dietary protein content, altering gut microbiome using pro and prebiotic, binding intestinal toxins precursor with carbon-based absorbents, AST-120 and sevelamer, reported in people. I'm not going and discuss further because we will soon discuss another paper on the use of the product available for cats. And they reported some limitation. Small sample size of cats monitored for 12 months before the onset of chronic kidney disease. And mostly the one that they were able to backtrack was even lower, only 15 cats. And obviously that can impact the statistical significance. The authors used urinary creatinine normalization, and they mentioned can be dependent on other factors rather than urinary dilution, for example, age, muscle mass, hydration. And so they suggest alternatives such as pre-analytical dilution of the urine sample to a fixed creatinine concentration, or the gold standard using 24 hours urine collection that it's not always easy or feasible in clinical setting, but those can have provided a more accurate representation. And then lastly, something that they discuss overall, like through the paper, they said the outcome has for chronic kidney disease as azotemic chronic kidney disease, so the development or decline of kidney function based on the creatinine value. And so obviously we know that there is a decrease in GFR way before the azotemic, when we can detect azotemic chronic kidney disease. So this is definitely different compared to humans paper. So for conclusion, circulating gut-derived uremic toxins, industrial sulfate, and TMAO increase at least 6 months before the diagnosis of azotemic chronic kidney disease. Direct cause relationship between toxins and initiation of chronic kidney disease in cats is still lacking. Few thoughts and potential next step. Is early therapeutic intervention targeting gut-derived uremic toxin warranted? And when we are talking about early, if we are still considering when the patient is azotemic, and for future study, can the use of the or the binding this uremic toxin can slow down the progression of chronic kidney disease or prevent chronic kidney disease associated complication. Again, we will discuss soon a paper that is using the product available for cats, but in human, sevelamer, that is a phosphate binder, is used also as proof the efficacy for binding the uremic toxins, and now that is more affordable, can be that also considered in our patients. And then if any of you use chronic dialysis in veterinary medicine, if any adjustment has been made or there is any consideration in removal of the gut uremic toxins. I thank you, all of you, for the attention. Any question or discussion, opinion?
I thought one of the interesting things from this paper was also that the SDMA was not elevated earlier than creatinine and wasn't actually beneficial in predicting the development of chronic kidney disease in these cats. So that was, I thought, an interesting side observation, not the major focus of the study, but
yeah. Okay. I guess.
There are two comments in the chat.
Oh.
I don't know if you can see those or if they require any further comment, but.
Oh, that is, hi, Dr. Harris. And then I feel I disagree. And it is the use of UST. Yep.
Also, just a quick question. When you're saying chronic dialysis, like as next steps, are you saying in cats? I mean, you know, dialyzing them for about 4 weeks can be sometimes common. And so would you be putting them in that type of category or even further out?
Yeah, I have few experience and most like in chronic dialysis. So I'm not sure. I guess for chronic dialysis, I meant who will use dialysis in end stage or chronic kidney patients, if who is performing that, if they are considering and adjusting the treatment, considering also the gut-derived uremic toxins, or if something that is still too soon in veterinary medicine. And I'm not sure how many of you will consider dialysis for chronic kidney disease in cats. Maybe it's more feasible in dogs. Okay, there are no other comments. Check
All
the
right.
chat.
Well, thank you very much. We will
Thank you.
go ahead and end then if there's nothing else, and we'll see everybody next week.
Great job. Thank you.
Thank you. Bye.